Welcome to another Techniques in Coloproctology virtual session. Associate editors Dr. Bruna Vailati and Dr. Leonardo Corbi are moderating today's session. And our presenter today is Dr. David Nijssen.
Leonardo, greetings.
Okay, welcome everyone. Welcome to another webinar from Techniques in Coloproctology. I'm Leonardo. I'm associate editor of the journal. Here is also Bruna Vailati, who is also associate editor. We're both here on behalf of Dr. Rodrigo, who is trying to connect, but is unable for the moment. And today we're gonna, Dr. David Nijssen is gonna present a recently published article, Hospital Costs of Different Treatment Strategies for Anastomotic Leakage After Total Mesorectal Excision, a multi-center cost analysis. So David, the floor is yours. We're here.
Yeah, thank you for the kind introduction. Let me just share my screen. So just a quick check, is everyone able to see my screen right now?
Yes.
Yeah? Nice, okay. Yeah, thanks for the introduction. My name is David Nijssen. I'm a surgical resident in Amsterdam. This study is a part of what I did for my work when I did a PhD at the academic center in Amsterdam. And I will talk a little bit about the economic impact of anastomotic leakage after colorectal surgery. And more specifically, I will be talking about this study that we recently published in October in Techniques of Coloproctology. But we did some additional studies on this topic, which I will also shortly touch upon. And I think it's an important topic because anastomotic leakage, especially after rectal cancer surgery, is very common. We see the more recent figures with incidence figures reaching up to 25% in case of low rectal cancer, which is a large amount of patients, and it causes a lot of morbidity. It can influence oncological outcomes as well, and it leads to more definitive stomas and even mortality. And another important topic is anastomotic leaks that are detected late or that lead to persisting anastomotic leakage, in which case we talk about pelvic sepsis, which is another extremely challenging surgical situation, which also imposes a lot of costs. So on the one hand, we are talking about a lot of new stuff that is focused on prevention and early detection, such as fluorescence angiography is making an upcome for technology to identify people at risk for anastomotic leakage. And on the other hand, we have all these different treatment strategies that are emerging in the last few years. And this is why we wanted to see how much costs are attributed to each one of those different strategies. But at first we started by looking into the literature. This is an article also in Techniques of Coloproctology, but we published this in 2024, in which we looked at studies that were looking for the same question of how much costs are attributed to this complication. And we found 17 studies from 12 different countries who looked into this. If you want to read the study, you can scan the QR code. And what we found was that there was a huge variety of reported costs. For example, you can see a study in Romania calculated an additional cost of about $2,000 extra. And in Brazil, there was a study by a group that estimated this cost to be nearly 90,000 euros, so $90,000, excuse me. So that's a huge difference. And we also saw that there was very limited quality and there was a lack of societal costs being implemented into their calculations. So the objective for this study was to see how much these costs were in the Netherlands after colorectal surgery. Specifically, we looked at the total mesorectal excisions and those costs associated with those strategies I was talking about earlier. Luckily, we have a very extensive and good guideline in the Netherlands that can help us with the methodology. So this is the one we used, which is from the Ministry of Health in the Netherlands. And we took the data from 15 centers in the Netherlands, 4 academic and 11 non-academic centers. And we calculated the costs for 4 different treatment scenarios, which I will explain later. And in this study, we looked at early anastomotic leakage, so all leaks that are detected within the first 30 days after surgery. And we looked at the costs during the first post-operative year. We included patients from the IMARI study, which was a national study that is now completed inclusion. But those are patients above 18 years old who underwent total mesorectal excision for rectal cancer. And because we wanted an even distribution of patients from all different centers, we took the first 10 consecutive patients from each hospital that was available in this database, so that we have an even distribution of academic and non-academic centers to give a more real-world reflection. So these were the treatment strategies that we included in our study. And this was based upon a worldwide study that was also done by our group looking into treatment of anastomotic leakage. The first group is salvage surgery, which is patients who either get a redo anastomosis, immediate or delayed, or they get a breakdown of the anastomosis with an end colostomy. Then the other two groups are the first one you see on the left side is the passive drainage group, which is a more conventional treatment of anastomotic leakage with leaving a drain inside the abdomen and creating a diverting stoma. And the one you see on the right is a more modern approach with the emergence of endoscopic vacuum therapy, where you use negative pressure systems to assist your drainage. And on the far right side, you see the no diversion group, which is a more conservative approach, probably also associated with the least severe leaks, treating, for example, with antibiotics. And these are the patients included in the current study. So most of them were male. We were looking at quite low tumors, so a median distance of 6 centimeters from the anal verge. This is a modern study, so compared to the ones we found in the literature study, we see here we have more modern techniques, so less open surgery, a lot of transanal surgery, like 1/3 of patients had a transanal surgery combined with either laparoscopy or robotic surgery. And these are the costs that we calculated and the categories that we used in the study. And the most important column, of course, is the total cost, where you can see that patients with an anastomotic leak imply almost 25,000 euros more in the first post-operative year. And most of the costs are explained by the hospitalization. So that is the most expensive part of these patients. And this is probably something that will differ amongst countries, but in our setting, this was the most important cost driver. As you can see, we also calculated the cost for each individual treatment strategies. And an important note to make with this is that, of course, not all treatment strategies are suited for each patient. So as I said before, probably the no diversion group will be associated with the least severe leaks, or patients with the least severe signs of anastomotic leakage. And the salvage surgery will be probably associated with more severe anastomotic leaks. But having said that, salvage surgery was the most expensive strategy. And as a close second, it was the active drainage group, which consisted of patients treated with endoscopic vacuum therapy. So here you can see the dispersion of costs. So to summarize what we found, the mean incremental costs in the first year were nearly 25,000 extra as opposed to people without anastomotic leakage. The biggest cost drivers were hospitalization and, of course, the reinterventions, and salvage surgery, as expected, was the highest cost, accounting for about 38,000 euros extra in the first year. I want to point out that we also did this article, which, because the total burden is, of course, not only in the first year. There are a lot of people who have late detection of anastomotic leakage because it is not recognized in the early postoperative phase. In the academic center in Amsterdam, we saw a lot of those patients who were referred to us who had diagnosed with anastomotic leakage around 3 or 4 months after the initial surgery. And they came to us with very elaborate pelvic sepsis, which is a very difficult condition to treat, with a lot of fibrosis around the anastomosis. And we also did a study with these patients in which we looked at the cost of treating those patients. which involves mostly a lot of complex salvage surgery, and that accounted to more than 30,000 euros per year extra for those patients. And having said that, you also have to account for that a lot of those patients will end up with a definitive colostomy, which is also very expensive. And that's only the hospital costs. So for the future, we are expanding the study as well. We conducted a prospective study to also look at the societal cost aspect. So we send out questionnaires to patients talking about their productivity losses. So that's productivity loss from work, people not having any societal contribution anymore, out of hospital care, and also costs associated with social support or rehabilitation services. And we plan to publish the study early 2026. So I would like to thank the people, of course, who I worked with on this project, and I'm very happy to answer any questions.
Well, thank you for the great presentation. It's indeed very anastomotic leakage is it's present in the life of every surgeon, and it's indeed very interesting to see the impact of it. The chat is open. If anyone has any questions, you can send it through the chat, and we'll report them to David. But I have two starters. The first one is a little bit of indication, which I don't know if I missed it, but when do you decide for an active drainage or a passive drainage? It's pretty obvious when you go straight to surgery, but what's the difference between going to active drainage and passive drainage? Because it has a pretty different cost, right?
Yeah. So I think it's dependent on the institution. So we included academic and non-academic institutions. Active drainage is a more emerging strategy, which has shown very good results, but it's not available in each hospital. So I would say passive drainage is the more conventional therapy, and the newer therapy is active drainage, which is not available in every hospital, but because we included these different hospitals, we could compare them. But the center that I worked at only used active drainage. The passive drainage they only used years ago. But I think, there are a lot of signs that active drainage is a very effective strategy for treating anastomotic leaks, especially if it's used within the first 3 weeks after surgery. After that, the differences become less.
Okay, that's interesting. And on a related question, of course, the costs are important, but we usually choose our treatment based on what's best for the patient, not necessarily cost-wise, right?
Yeah.
So what is the actual importance of the study? I mean, sometimes people would say, this is pretty obvious. If you operate a person, it's more costly. If you do active drainage, it's more costly. So what is the importance that you actually study it and put it on paper for the scientific journal like ours?
Yeah, I think that's a very good question, because we thought a lot about this and we had a lot of discussion about this. In the initial version of the study, I also added a clinical outcome table of each different treatment strategy. So we compared the outcomes in terms of being stoma-free at 1 year and having a fully healed anastomosis at 1 year for all the different treatment strategies. But the problem is that the goal of this cost study is not to compare the different treatment strategies in terms of clinical outcomes, because it's not fair to do so, because all the patients included in those groups have a different severity of anastomotic leakage, why you choose a different treatment strategy. So this is just to reflect each scenario and how much does it cost, and how you can use it is if you want to implement a new treatment strategy for one of those scenarios, or a new strategy for prevention or early detection, you can use this data to calculate cost effectiveness.
Okay, very interesting. I asked this, but I actually agree with you. Even if we don't actually, I know you can assess cost effectiveness, but if you actually choose your treatment based on on the clinical setting, it's also important that you know the impact of that on your own institution, whether it's a private institution or a social medicine, let's say, like this, like a public service that we have here in Brazil sometimes, and probably you have there in Amsterdam or not. Is it private or a public system?
It's a public system.
Okay. So it's even more important, I would say, right?
Yeah, it's very important. Yeah, and but it also makes it easier, but because it's a public system, like this data can be used nationally. If it's a private system, it will differ across all institutions. But of course, all hospitals also make their own appointment with healthcare insurance companies. So the prices we use are a little bit different for each hospital, but we try to make a good estimate of what it would be nationally. But it's always an estimate, these kinds of studies.
Of course.
Okay. I have one question. I'm not sure if you mentioned it, but in the group with no diversion, do you sometimes use drainage by CT scan or guided by some imaging testing?
No. That would be the passive drainage group then. So the no diversion group is patients who are not diverted and who are, for example, treated conservatively with antibiotics, who have very minor extravasation at a CT scan. Yeah, but that was also only one patient, so that's not very the data for that is not very strong.
Okay, and do you have an idea, because you don't use protective ileostomy for every cases, but do you have an idea what would be the additional cost if you use protective ileostomy for all these patients?
Yeah, so in our institution, it was around 3,000 euros, a protective ileostomy. But if it's part of the surgery, initial surgery, it's probably a bit cheaper because it's more efficient. But I know from that there's a huge difference in how hospitals in the Netherlands approach this. In terms of a lot of hospitals prefer to use a protective ileostomy, but the hospital I worked at was very selective in doing so. And what we also see in some of the other data we have is that if people get a protective ileostomy, it also seems to delay the diagnosis of anastomotic leakage. So in the initial stage, the rate of anastomotic leaks in the patient groups with an ileostomy seems lower, but then if you look after 2 or 3 months, those patients are diagnosed with a leak, which is already more confined in the pelvis with fibrosis and is actually more challenging. So that's one of the reasons why we prefer not to do so much ileostomies.
Okay.
I think Diana wants to say something.
I just wanted to let everybody know that the link to the article is in the chat. So you can go read the full article by clicking on the link.
Okay, that's nice. So if we don't have any more questions, I want to thank David for the great presentation. Looking forward to new presentations here at Techniques. Thank you, Dina. Thanks, Bruna. And see you next webinar.
Yeah, thank you for your attention. Thank you very much.
Thank you.
Thank you,
Excellent.
David. Thank you, Gina.
Have a great day.
Bye. You too. Thank you for joining us today and watching this brief presentation on the hospital costs of different treatment strategies. Be sure to subscribe to our YouTube channel to receive notifications about future interviews at Coloproctology, and visit the journal at springer.com to read more intriguing articles. See you next time.